All right. You can see us and hear us very well, right?
Absolutely.
Oh, beautiful, beautiful. Okay, Ashok, and of course, we got all the panelists, and again, give thanks to TAVI Now, this new program, second year and now, showing the latest in the field of TAVI, and we'll do our part to show here from Mount Sinai, and good evening to all there, myself, and then Dr. Keeney, my left side, Dr. Gilbert Tang on my right side, and Parashuram, another our structural attending, and then we have fellow, structure fellow, Supawat. And then Dr. Stem Larakas is on the echo. This is the case getting TE, and then Dr. Fried. Eric Fried is the anesthesiologist. And of course, rest of the staff in the room. We want to show the case which they wanted, the Darwin valve, and that's what we are going to show now. Let me just start here. These are our faculty. So what we are going to show is valve-in-valve TAVI with a 23 millimeter plus 1 cc Sapien 3 Resilia in 23 millimeter Magna Ease surgical valve degeneration causing severe prosthetic regurgitation, not a PVL, it was a regurgitation plus moderate aortic stenosis also. This is the patient, 64, already had the surgical valve, that time had some issues, 23 millimeter Magna Ease plus aortic root enlargement, ascending aorta replacement, and then complicated by type B aortic dissection. And that goes from aortic arch up to aortic-iliac bifurcation. Also a lot of comorbid conditions, and CAD is fine, but TTE show moderate to severe bioprosthetic AR with moderate AS, and also this patient has moderate to severe MR with MAC, and of course mild to moderate TR. So always question comes, what you do with a moderate to severe MR and you have moderate to severe bioprosthetic aortic regurgitation. If patient is suitable, you go for second valve because patient is 64 years age. But if patient is very high risk because of, not necessarily because of the STS mortality, this patient has STS of about 1.5 and 6, but because of the other conditions, which is Hodgkin's lymphoma, and more importantly with the chronic aortic dissection. And I'll ask maybe Gilbert to comment on it, that what is the strategy on this patient, because he has been heavily involved with Anu. Yeah, Gilbert?
Yeah, no, this is a very challenging case, even looks deceptively simple. You can actually show aortogram in the CT. Patient actually has a porcelain aorta, despite the ascending aortic replacement, which is a very short graft, and very likely because of Hodgkin lymphoma radiation. Back then, you know, they were very extensive due into radiation. The type B dissection, I think, will make it challenging from an access standpoint. We'll talk about that later. But more importantly, aortic root enlargement is a relative contraindication to balloon valve fracture. I think people do not understand, especially with replacement, you do not have a continuity between the aorta and the ventricle anymore. So if you use a high pressure balloon fracture, you can actually rupture the annulus, and that's been reported. So in this case, the patient incidentally was actually presented with MAC, severe MR as the primary presentation. We were evaluating the patient for Apollo trial, and actually was approved. But then on the TEE, Dr. Larakas showed that, oh, there's also prosthetic valve degeneration. And because it's part of a trial, the committee wanted us to fix the aortic valve first, and that's why we're here.
Okay, can we go to the fluoro and show that fluoro actually, how the axial aorta, just go to the fluoro please, one time.
Yeah, you can show the aortogram.
Yeah. You want to just make a little stene? Yeah. Yeah. Good.
Yeah, right here.
This is all because of the radiation.
Yeah.
Yeah.
So you can see very well where the catheters are right of the aortic valve. You can see the outline of the aorta.
Yeah.
And you can see it more impressive on CT later on.
So therefore, this is a two-stage approach on this case. I know you are following this patient. Is there any dehiscence of the aortic valve, or is it just regurgitation with the degeneration? Knowing the surgical valve has been for about 11 years now.
No dehiscence, mostly is aortic regurgitation with valve degeneration. Yes.
Okay. All right, let's go back to our presentation, and then we get up because we get about 35 minutes of slides again, please. Quickly go through and we start crossing it. Okay, this is the TE echo, and now this was there, and we can do the live echo now. The stem.
Yes, good morning.
Can we go to the live echo, please? Yeah.
Yes, good morning from New York. I have our structural fellow, imaging fellow, Dr. Prati. As you can see here, normal LV function, 4-chamber view, you can appreciate the severe calcification of the mitral annulus from most likely because of the radiation of this patient. The RV function looks normal. As you can see here, severe mitral regurgitation, mild tricuspid regurgitation this morning, mild pulmonary hypertension, about systolic pressure about 40 millimeters mercury, clear left lateral appendage. You can see here the aortic valve severely degenerated with thickened leaflets, immobile left corresponding cusp of this bioprosthesis. This is an X-plane view of the valve. You can see the severely degenerated valve together with the proximal graft of the ascending aorta. This color with color, you can appreciate the turbulent flow as well as the mild to moderate aortic regurgitation that we see here. This is the aortic annulus. This is the gradient that we get together today, 3.5 meters per second.
Why became more aortic stenosis also now?
Yeah, peak gradient of 48, mean gradient of 27. Putting all together, today we get actually severe aortic stenosis on this patient with mild to moderate aortic regurgitation. This is the deep gastric view. X-plane, you can appreciate the severely degenerated valve, thickened leaflets, and the proximal aortic graft. This is the mild to moderate aortic regurgitation, as you can see here, and it's valvular. You can see that from the X-plane. And this is the thrombosed, the false lumen of the aortic dissection that this patient has documented. And this is the short axis view, gastric view of the LV to show that there is no pericardial effusion starting with. Thank you very much.
Beautiful. All right. So let's go to presentation. Let's resume the presentation. So we complete the case and then we start ready. Go back to the slides, please. Okay. So, nope. Slides is still not the fluoro. Yeah. So we have already gone through this part and then.
Get a AR.
Yeah. So coronaries were okay. Not an issue. And the CT analysis, Gilbert, anything particular?
Yeah, no, nothing particular. This is a 23 Magna Ease valve. You can see the internal diameter is very consistent, very large sinuses and STJ. So maybe the patient had a bicuspid valve earlier on because he's young, right?
Yeah.
So anyway, next slide.
Yeah. Sorry, there is a question, Ashok.
Yes. And
Yeah.
while you carry on with the case, I think with Gilbert, we can have this discussion.
Yeah.
We got a 23 millimeter Magna Ease. It's ID of 21 millimeters. Why not consider a supraannular valve rather than put in another small valve into a small valve? Fine, he may have Hodgkin's, etc. But
Yeah, great question, actually.
For
If you,
and against, and I think it's a point of discussion.
Yeah,
yeah, absolutely. So next, if you go next slide. So this is a very
Go back. Yeah.
So this valve is implanted supraannular, just like all surgical valves. But look at the left main height.
Okay.
Left main height is barely 1 millimeter, and this patient is only 64.
Yeah.
You agree with you?
Yeah.
So this patient will likely need to come back for lifetime management. So the concern with a supraannular self-expanding valve, tall valve in general, is that it's going to be very hard to get back to that coronary. I mean, if you have to go outside the frame, it's not that straightforward. So we think that even at the risk of putting an intraannular balloon expander valve, you can definitely get a supraannular self-expander in the future when this valve degenerates. So we can actually potentially do 2 lifetime management intervention on this patient, not just one potentially only.
So that's the Ashok, that's the reason because of the very low coronary height. Now question is, we'll have the same issue a few years later. 10 years later, when we have, maybe that time we'll have a little better supraannular valves, navitor and various types which will have a better coronary access.
And Gilbert knows that we can argue against that by saying you could have a faster degeneration of a small valve and a slower degeneration of a supraannular valve, perhaps better durability. The coronaries didn't show any significant coronary stenosis. His likelihood of needing coronary interventions in the near future is minimal. He has a lifetime management of Hodgkin's lymphoma with chemotherapy, and he may not outlast this valve.
Samir and Gilbert, fantastic case. It's written all over the case. It's written complexity, right, starting from the aortic level, as Gilbert has already alluded. It's a replaced ascending aorta, so that junction is notorious for giving away.
Can you show us T?
There is a dissection from the descending aorta going to aorto-iliacs. Now the access and how you manage the access, we are sort of very keen to see that.
Yeah, we'll show that also. Yeah.
Yes.
Beautiful case. Yep.
Yeah. Yeah, we will show you
The
for
corner
sure.
is-
Yeah.
Okay. So let's go to our this is
Next
okay.
slide. I just
Yeah.
will finish up the slides quickly. I just want to bring up the point. This patient presented with moderate severe MI MAC. The prosthetic aortic valve degeneration was actually more like a secondary finding. So you can see we actually screened the patient for the Medtronic Voyager valve. This is a new 29 French system for the Apollo trial. And you can see that the neo LVOT is wide open, almost 300 millimeter square. She's already approved for the 42 millimeter device. So we're going to bring her back 90 days after today's intervention for the part of trial. So I just want to show you that that she will be a candidate. Maybe we can show that in the future.
Yeah,
Next slide.
and this will be a transeptal. It's working
That's
out
right.
particularly 29 millimeter. This is
29 French, and it is
29
percutaneous now.
French. It's a big thing because, remember original trial of the EFS, still have a lot of venous complications. But now, hopefully, with the new one, have we done any case with the 29?
No,
yet?
it's coming up because
this
of
is
this
the first-
delay.
Yeah, we have one or two cases lined up now with a 29 millimeter, but all being done percutaneously with a total valve replacement. Superb, superb. I know there is a whole race is going on with the TMVR, but I think everything is a little slowed. Whether who will win, we need to see in America, 10-9 versus Apollo with the Voyager and all. We'll need to see. Okay, next go to ilio. Yeah, this is the bifurcation, and you can see the false lumen with the aortic dissection right there, and the valve in valve, right? We agree with that.
Yeah, so
arteriolia.
exactly. So to the panel's point, these are the discussion we just talked about, right? In terms of which valve to choose, and we choose a balloon expander valve for this particular understanding. There are limitations, right?
And clearly, why we cannot fracture this for obvious reasons, because otherwise we'll probably have an aortic rupture. So no fracture, although this valve can be fractured. Magna Ease can be fractured, and you can increase the dimension, but this case, for obvious reasons, will not be fractured. That was the plan. And here it is, looks like fit nicely. And let me just complete the case with the valve in valve TAVI. Now show the access point of view. Let's quickly go to the fluoro, please. And Parusham will show what was about the dissection lumen.
Did you show the CT?
Yeah, good morning, everyone.
Yeah, sure. Yeah.
Our plan was actually to go right main axis, as we already know that the dissection extends from the mid-aortic arch to the left external iliac vein. We had a couple of options regarding bailout we always have, and also for the pigtail, which we don't need in this case technically, as it's valve in valve and TE guided. Our options were either we go left groin for the bailout and the pigtail, or we go ipsilateral, same side, right groin, because the patient actually has a large CFA and the iliacs in the right side are actually larger than 7 millimeters. And those are the two criteria that we usually screen for patients who have ipsilateral aortic aortogram and bailout axis for the CFA superior and the inferior CFA stick, or CFA and SFA stick. We actually did not go with that option because she's morbidly obese, and the distal axis in the CFA or the SFA, there's this much amount of adiposity, more than like few centimeters. So we realized that if we have to close that axis, it's hard, and if you need to do manual, it's going to be hard, and we may end up with more complications. Hence, we actually went with and the third option was actually going radial. Unfortunately, she didn't have the best right radial pulse either. So we actually stuck to our original plan of usual conventional method, which is going on the left groin with a 5-French pigtail axis. And we confirmed that this is the left femoral vein, and this is the left femoral artery. It was ultrasound axis. And
you have the picture that you're in the true lumen?
yeah, we have the picture. We are in the true lumen. We fluoro saved the wire going in, and also we actually have, I don't know, yeah, there it is.
Yeah, good.
So this is the anterior stick on the distal CFA, and this is the wire and the pigtail that's going up in the true lumen, which we confirmed by the picture and also with the TEE. And then we usually do up and over with the bailout V18 wire or 018 wire across from the contralateral side, but we avoided this because of two reasons. The amount of calcium or the hostileness of the main axis side was not there, so we were comfortable using just 2 preclose and maybe an angioseal on the way out if we still needed to actually bail out. and also more problematic in this person, especially with the dissections. So that's why we didn't do an up and over access across the aortic bifurcation going to the other side. And again, this was an ultrasound access anterior stick. Like we can see here, the CFA is super long.
Yeah.
So it has been a beautiful case for an ipsilateral access if it was not for the adiposity and the inability to reach the closure for the distal CFA access. But you can see here, there's an ultrasound guided center stick, no calcium. And this is another one that's proving that we were actually in the true lumen. And with that, yeah, this is the aortogram. Yeah,
Severe
that
AI.
actually showed severe AI.
And actually show the hemodynamic also. This is the case now. Severe AI and moderate to severe AS. We can put a hemodynamic on the bottom line, and Anu tell us the crossing the valve and so.
Yeah.
Or hemo, put it there
we show
before,
the
before
hemo
we go
by the
further.
side?
Can they show the hemodynamics? Okay. Always should be, guys. Hemodynamics always should be there. Yeah. Good. So the significant gradient also. Yep.
Ideally, when you have this surgical prosthetic valve, we would like to use AR1 to cross and likely the RAO view rather than the typical LAO view. Here, because of the reconstruction, root dilation, the root definitely was dilated. So I think we can show you how we crossed. We had to use next one.
Yeah, this one.
Okay, good. It's not playing either.
Yeah. Play.
Yes, this was our AR2, and I had to go to the LAO view to get into to see on pause, make sure we are in facing the valve.
So use
properly.
the AR2 or AR1?
Use AR1. Here we have to use AR2.
I see.
Yeah.
Okay.
So Dr.
And,
Kinney, can you comment to the audience about large aortic root, small prosthesis, right? Because this is the
Yes.
situation. What are your tricks?
So same, ideally would be AR1, we went to AR2, and then you have to keep rotating. You see that? You have to go to a view where you can see the center of the valve.
That's right. Yeah, no, I think
Ideally, I told RAO would be better, but in this case, RAO would not. Look at it, we are in LAO.
well,
very
the
rarely we
patient's
go
very
to LAO.
rotated root.
Yeah.
That's the issue. The anatomy is very rotated. And to your point, you kept hitting the sinuses otherwise, right? In a big sinus situation.
Okay.
So very nice.
Clock, counterclock with your left hand, the catheter within AR2, and then use your straight Terumo wire. You see that?
Yep.
Be gentle, right?
Okay.
Not go in the side and all that, Then we get it to the pigtail. So we are with the...
Yeah. Sometimes you can also use TE to help in terms of
Yes.
looking at where the catheter is going towards the center as well, especially crossing sutureless valve. You know, suture valve has a tall frame, and sometimes you can cross through the frame, and that can be a disaster in terms of doing like a Percival, for example, in some parts of the world that has those valves being done, and definitely for TAVR and TAVR. So TAVR and TAVR with tall valves, make sure you don't cross through the frame, especially when the big cells, because then you will not be able to advance the second valve through, and it could be a big problem. So
That's one. Now in this case, it's more of an AI and moderate AS. So we know very rare we have cases where it is degeneration and severe AS of the prosthetic valve. In that situation, we may have to change to V18 wire even to get into, because of the stenosis is so tight. You may need a V18 wire to get across. So the other catheters, okay, AR1, AR2 we discussed. If it's really dilated root, we have maybe a AL1. But many times even simple JR catheter also does help if the root is really small. Okay, we have the valve
What wire do
facility.
you have in the LV cavity?
Safari.
Supracore.
Safari.
No, Safari.
This is Safari.
Safari.
Safari extra small. That's our default wire now. We still use Lundequist sometimes for very tortuous and angulated anatomy to help. And if you can also use from the contralateral side another stiff wire to kind of put buddy wire to help as well in some situations. So
You want to come? Go in the front.
Okay. Adjustment of the valve.
Yes. Advanced SAVR.
Now I know the Sapien, the Resilia is not available. Ultra is available in India, but they say first quarter of next year. As you know, at Sinai, we changed completely. All cases are done with Regelia because there are some data that gives you better hemodynamics.
This angle, go for it.
Okay, go.
So definitely they'll put a little extra premium on that in India of the Regelia. But I think it's a better. In the beginning, we were actually selecting which case should get it. Then we made a deal with our Edward team. I say, this is the better valve. Who cares? Some even 80-year-old sometimes can live till the age of 95.
No, we did. We had a patient who had a core valve when you did it.
Yep.
Right, lived for 10 years from 80, now become 90, and we have to deal with valve and TAF.
Yeah.
Okay.
Okay, I'm getting more flex.
Okay.
Yeah.
All right, tell us what you are doing.
No, initially I removed the flex. Now I've given more flex to bring it to the center of the valve. You see that? Right?
Yeah, good. That's a good
Now
thing.
you want to move a little bit?
There's a lot of PVCs without even asking to go the fastest.
Yeah, I'm going to bring back the wire a little bit so that left avoid the PVC. See? Okay, good. I think it's just very irritable heart.
Very irritable, yeah.
It's coming out.
Yeah. Now it's okay.
Good.
Okay, now let's pace and see.
And because of calcification, we did not put a central in this case.
Yeah.
Also
Dissection also, yeah.
Dissection, calcification, tortuosity of the ascending aorta and the vessels.
Otherwise, this is the case that will need it, yeah? Go, 180.
Yeah.
Sine. Good.
Looking good.
Off. Okay, so you'll adjust as I go.
Everybody agrees? Looks good?
Yes. Gilbert, you happy? Pull back a little.
No, go. No, that's good.
Okay, 180.
a lot of parallax.
I'm going to. So a slow inflation, and Parasuram is going to adjust if we need it. No, too much.
Good.
That's
Okay,
good.
now.
That's good. Very good. Nice.
1,000, 2, 1,000, 3, 1,000, 4, 1,000,
And once
5,
you know you're in the
1,000.
right spot, just go.
Long pacing.
Okay. Yes. We may
Come
have to
back
do
out and
second
do a
time.
second one.
Oh, yeah.
Yeah. Off pacer.
So what we learned, just like our coronary stenting, remember we do a two inflation. So this valve in valve, TAV in TAV, because first one will expand with the resistance of the valve. Second one will do a little better circular expansion. I mean, it's maybe a theoretical, but makes us feel good. I don't know what you do, Ashok.
No, there's always a little bit
This
of
is-
recoil,
this is
right? So
Absolutely fair with the
Yeah.
valve and valve.
Go.
Yeah.
To
Okay.
actually do a second dilatation.
Yeah.
Do you need more?
no.
We're going
Same.
to post.
Actually,
Okay,
that
we're
you know
going
with
to
the
go.
1
line.
second, Sam.
180.
Okay. I'll tell you 1 second.
Wait. Okay, off.
Off.
That's like 120. That's like 120 and hyperdynamic.
Yeah. Okay, go 120 first.
120.
Okay.
115.
150, then 180. Still not. 180.
180.
Just
Wow.
MRTR.
Yes, okay. No.
Good. It should
Let's
go.
see. Let's see.
Yep, that's better. That's
Okay, good.
See that?
I did a full.
Sine. Good. Oh.
So this
Okay,
this
good.
concept
Off.
Off.
Yeah.
Pigtail ready, please.
Wait. Come down slowly.
Yeah. Unflex.
Yes,
Unflex
Ashok, yeah.
completely. Yes. Get the pigtail.
No, I was supporting this double inflating twice because even for stents,
Yeah.
it has been well demonstrated that two
You
inflations
got wire?
Yes.
Yeah.
Good.
I got
Okay. Pigtail.
get you a larger MSAs, and of course with stent in stent
Yeah.
or valve in valve, it's clearly the right options.
Yeah, and remember on April 28th. Yeah.
Better EOAs and better expansion. And we must remember that this is a 23 plus 1 in a 23 with an ID of 21.
One moment. Let's get the pigtail in, and then you can show hemodynamics and then the TE. Okay.
That was a
Stamp.
nice demonstration,
Yes.
Annapurna. I think the distal flex allows you to keep it in coaxial before kind of inflating, and that's a perfect demonstration of that. Especially when you're doing this valve in valves, it will cant towards one side. So the advantage of the distal flex with Edwards makes it that you can keep it coaxial even before sort of deploying, and very slow deployment is the key. Make it sort of allow it to contact with the surgical.
Okay,
valve,
Stam, go
then
ahead,
you
please.
full on.
Absolutely.
All right, so Stam's going to show us some nice echo images. Please go to echo, please, for the audience.
Now let's see the hemodynamic first.
And no, hemodynamics, you see it here.
Yeah, see hemodynamics, no
Picture in
gradient.
picture. Excellent. Very nice.
Beautiful.
You want to do re-zero?
No, right there, zero. Is zero itself. No
Oh,
gradient.
good.
Okay. And now the echo.
Good.
Yeah, no gradient.
Beautiful, no AI.
The AI index is good. The
Okay.
diastolics have gone up.
Yeah.
Okay, let's
And
go.
there's no
So,
gradient.
to the please.
One thing we see is that patient with prosthetic AR, once you deploy the valve, you have very hard time to pace again because they now have no AR.
Yeah.
So they now it's
That's
very
true.
hard to get the waveform down. That's why we had to slowly ramp up the pacing to make it work.
Explain there, explain.
Looks good, Stam?
Yeah, very good, very good. Put some color, please. Bring the color down.
Very nice.
Yeah, beautiful.
So again, I mean, there's a lot of debate from the SMART trial about, invasive versus echo gradients. And at least from the hemodynamic standpoint, with very good blood pressure, there was no invasive gradient. So, time will tell. With this patient, is going to follow up, obviously, part of the Apollo trial of at least 5 years out. In terms of, we'll obviously look at both the aortic and the mitral valve to see what will happen in the long run.
And
Arch angiogram?
yeah.
Post-arch angiogram?
Yeah, do an aortogram. Yeah. And
no,
same thing.
means,
One also decision was Ashok and that panelist there that Resillia. So we expect Resillia will outlast more than 10 years. So if really even it's a smaller valve, the expectation we don't know because we are just doing for 1.5 years
take
now.
this out. Yeah.
But it has been a superb from point of view, and I know that when they bring it
is
to
done.
India,
Pull up.
they'll have some premium. But I think they need to be very
to increase
careful
a little bit.
because we need to increase the Edward
much you want?
use
14?
in the country. Here is 78% in USA.
10 for 12.
Deploying about 8,000
Yeah,
TAVI valves per month here, and about 78% is the market
15
share
is
of
good.
the Edward. And I know it's much lower there, knowing the 50% being the my valve, but otherwise also. But very good valve, very quick, dependable, as you can see. Not to say anything bad about other valves because we started our
Stam,
life
can
in the
you put a
Medtronic.
prop up, please? We can do
the
an arch
core valve.
angiogram, please.
Take that,
Thank
please.
you.
Yeah, okay, take that.
T up.
Yeah.
Take it.
Okay, we're doing the aortogram now. Yeah.
Hi, Dr. Mark, Dr. Kiri,
Up,
Dr.
please.
Bhupati here.
Can you?
Yes, Bhupati.
Yeah.
Bhupati, hey, Bhupati.
Can you pull a T up further, please?
Okay.
Good.
When do you consider
Yeah.
bioprosthetic fracture in your practice there? If let's suppose this patient may not need it.
Yeah, we routinely like to do it. This patient, like I said, if we only have isolated SAVR, we will fracture it, no question.
Yeah.
But obviously, you have to look at the risk of coronary obstruction. Remember, when you fracture the valve, your VTC or VTSTJ may be smaller. So just beware that you might actually acutely occlude the coronary if you're not paying attention because you had not predictably fractured in a certain direction. So, and then some valves are not fracturable, as you know from Dr. Vinny Bapat's app. So just, he now actually give you a recommendation on the balloon, recommended fracture balloon. So you can just go with the app.
So coming back to the question of Bhupati, that which valve you to be fractured, one, which are fracturable. Even in the fracturable, the data are, you fracture the valve, you not fracture the valve, patient will do fracture, have more complication than you don't fracture.
Yeah.
So where would you do it? Like this ideal case, you have a small valve, and you want to get a bigger lumen, so this is the case will fracture. Now this patient happens with a lower BSA and happens at age of 85, we probably will not fracture. Yeah. And then second question comes, one is the fracture, if you avoid, good, but you may have to do it to increase the lumen. Second question is, do you fracture pre or post? Now I think we learned it now, is the pre better than post. So all the data have shown that if you need to fracture, you do a pre, not post.
Yeah, so in this particular case, we've done before we start fracturing, we can post dilate like here and still expand and drop the gradient, even for self-expanding valve as well. So if you worry about fracturing and cause harm to the patient, don't do it, but you can post dilate safely. Just use the same balloon as what the companies recommend.
So just to pass on your messages, because there's three sources of information coming in between you. Messaging. The pre-fracture issue, we've just messaged to them that the advantages or disadvantages of pre-fracture versus post. There's clearly one disadvantage you can't do away with. You pre-fracture, you're committing yourself to valve fracture. We still don't know the consequences of valve fracture in the long term. Your second point is that it could create a severe aortic regurgitation, severe enough to cause a collapse on the table. It's happened to some of us in our lifetime, and therefore for me, a valve predilatation is a no-no phenomenon. And finally, many valves are modifiable. You don't need to fracture it. For example, your second balloon dilatation could have modified the valve to give you zero gradients. So you don't necessarily need to fracture valves. You need to modify valves far more than you fracture. So I want to just convey direct messaging, which I don't think we have a jury out for pre-fracture versus post-fracture.
Yeah,
I mean, just because publications. I mean,
yeah, there are some TBT registry data that show pre versus post. There's some differences, but like I said, treat the patient, not the numbers.
Yeah, and I think same thing. Ashok, clearly in these symposia, we have to give a clear message to the audience. Audience message is, as you said, if not needed, don't fracture. So then you don't know what complication can occur. In kind of this case, younger patient, you may decide, but then the jury is, the difference is whether you pre or post based on the TVT data published in the JAC intervention, that maybe pre is better. Now, we actually used to do post. And I know that Raj Makkar used to do post also, but they all have shifted to a pre when I spoke to him last time, just based on, because we did have one trouble. One patient.
We could not be fractured.
Yeah, could not be fractured, and then we developed severe AI. One patient with after the post fracture, we thought we'll do it, but rarely we do. We learn going away from it, and in rare case when we'll do it pre if needed. So just to message clear, don't make it a routine habit of, even if it's a fracture of a valve, don't fracture it if not needed.
I want to show this. We want to actually show you this a final aortogram. So you can see the top of the sapien resilia is at the top of the commissural post-surgical valve. We plan it this way because now, if you talk about TAV in TAV, your neoscur is not going to be higher. Had you put this sapien valve higher, your neoscur will be higher. You can see the angulated band of the aorta towards the left main. So had you put a tall valve in now, first time, it's going to be challenging. But even now, if you had to put this one higher, too high, and then now you actually might box yourself out of TAV in TAV option. That's by looking at the aortogram. So CT is helpful, but we still look at the aortogram as a final tiebreaker for a lot of these procedural planning.
All right. Any other question? Yeah.
We do think that was a great choice. And what you have as a result, clearly, lifetime management is a reality. When you just put this balloon expandable valve in valve, you have zero gradients, and you have an option forever open. I was going to ask you, again, for the benefit of the audience.
Yes.
Obviously, this was not a case for cerebral protection, primarily because of the previous aortic arch, the dissection in the aorta, the radials were poor. But what's your strategy for valve in valves with a degenerated valve like this? Is cerebral protection your norm in such cases?
100%. 100%. Yeah. Okay. And now we're actually getting into the few other trials. Now this one was the right radial. One of the big reasons we are getting, many patients have caths in there, radials have gone, about 10-12% of cases. We cannot put a sentinel because right radial is gone. But now the new devices, Protembis and we on the another new cerebral protection device, we thought this field is gone. Field is not gone. There's still like 3 new devices are being tried at this time. And we will be starting a trial with the Protembis, which goes from the left side. So at least have some option.
Dr. Tang, we have got 3 other panelists in the panel. Prashant, and Nagendra is here. Any comments?
Nagendra. Yep. Two of the people are trained from Mount Sinai.
Yes.
How do you like that?
Prashant and Bhupati.
Good to see you, Dr. Sharma and Dr. Kini and Dr. Tang. It's really commendable on Saturday morning at Mount Sinai after this GZT Live Symposium.
We had a symposium, yes.
Well, we did 10 live cases yesterday. And of course, now we had Tuesday our live case, CCC live. Then Friday we have Boston Scientific Meet the Master. So the whole week continues. But really, listen, there's an opportunity for us to showcase. And most important is go to the individual point, the discussion which we have today. That take home 3 or 4 points with the audience and do it as good we have been doing. Now, things are working very good. Complication of the tower has been less than 1%, 30 days nowadays. Okay, we came up to the time.
Again here.
Yeah.
Just one small question to you and Dr. Tang. In valve-in-valve case, the shortening may not happen from the lower end because the interaction may be different. So can you give some highlight on that?
So good question. But the TAV in SAV, like today's case, there's not that much. It's mostly from the bottom. But TAV in TAV, absolutely. We've done TAV in TAV live cases now. You can look up our ccclivecases.org website to look at our past cases. The SAPIEN, when you put in either an Evolut or SAPIEN, can foreshorten from the top a little bit as well. So just be careful. That's why Dr. Keeney showed a very nice technique of really slow inflation, and you have to tell your anesthesiologist it's going to be a long pacing run, so they don't, get distracted and prepare to intervene if we need to. So I think that's very. Parasum, any final point on that in terms of the TAV in TAV versus TAV in SAV?
Yeah, I agree. The expansion actually happens on both the sides, and we've seen more in the TAV in TAV cases, and that's why we usually actually start a little lower than what we think we should be, especially if the foreshortening happens, and if it's from both the sides, you're going to expect more shallow than where you are at the final deployment position.
Yeah, so you have to make sure you don't obstruct the coronary by mistake, or you don't want to embolize into the ventricle if it's for sure from the top. So you have to just go fine adjustment with the two operators.
Okay. All right, I think we got to our 35 minutes, so, unless you have any comments. Yeah.
No, I was just going to ask other colleagues whether they had any comments. And yes.
I think what is your protocol for a sentinel device in valve-in-valve? Because the stroke incidence is relatively much higher in valve-in-valve.
He said that he's answered that. He said 100%.
100%. Like this case, not a question. Yeah. Because these are the patients who will get trouble. Yeah.
And so there's just one final question and a comment. I think you got to see, when we fracture, we actually expand that valve.
Yeah.
Do you actually take into consideration your original valve size to compensate for that expansion? The size changes, and it can change by 2 or 3 millimeters. That's an important issue when you have to size a valve.
Yeah, with balloon expandable valve, it's less an issue. The self-expanding valve, yes. So you don't want to undersize a self-expanding valve, so you have to anticipate for that, especially a 23 millimeter surgical valve or 25 millimeter. There can be sizing in between. So that's where the pre versus post fracture comes in, because if you pick a larger valve, then you have a bigger mismatch and you might have a trouble implanting at the right depth. You might implant too high now, then you cannot fracture afterwards, right? So if you tend to fracture afterwards, implant a little deeper because it's going to foreshorten from the base. If you fracture before that, you have less of that issue. But to your point that you might have acute AR, so we always have the valve ready to go. When we deploy, and we deploy very quickly, at least up to the functional aspect of the self-expanding valve, Evolut or Navitor, so that at least you take care of the AI first. If you need to, you can always recapture and reposition.
All right.
Thank you very much. There's one final question to Gilbert.
Okay.
This valve-in-valves, especially the small valve-in-valves, like the one you showed, there is no sort of sinus washout at all. What is your protocol? Antiplatelets, anticoagulants, NOACs? What do you do with this?
Dr. Sharma, you want to make
a comment? I think it still remain
antiplatelets only. Yeah.
Yes, this patient might meet, well, actually, funny you ask, this patient is going to go to an Apollo trial. Patient will need to be on Coumadin anyway for at least 3 months. So, but if they can tolerate anticoagulation, at least DOAC was reasonable. But a lot of these patients, as you know, has other risk factors like AFib and so forth. So they're on anticoagulation anyway.
But just
so going back to DAPT, tell them what's our DAPT protocol.
But, I mean, otherwise they all know is the aspirin. Many of the cases we are just giving aspirin alone. Elderly patient, 90-year-old, you don't need any even dual. Otherwise, 3 months of DAPT with the clopidogrel for 3 months. But otherwise, routinely for a non-AFib or non-anticoagulation indication, we are not doing even in valve-in-valve. Although maybe some data that anticoagulation may be better, but particularly for the Apollo, for the TMVR, we need to give a 3 months. They prefer warfarin more than even NOAC, but sometimes NOAC is given there. So this patient will be ready at 60 days for the TMVR. Till that time, we'll get just aspirin and clopidogrel.
Yeah, there are actually 2 registries. One actually just presented New York Valve with the 3-year data from SAPIEN in degenerate bioprosthetic aortic valve, 3 year from the TBT follow-up. There have been really no early signs of reintervention, and same as the partner bioprosthetic valve registry in terms of the failed SAV with SAPIEN. So at least that's encouraging so far.
Yeah. Okay.
Great. Thank you very much.
Thank you. Beautiful.
Right.
Annapurna, Gilbert Tang, and the team for a great case demonstration. Thank you all.
All right. Thank you.
Thank you. Bye-bye.
Bye-bye.